Yeah, maybe it's okay.
The expression on your face is just priceless. Are we live?
Maybe
Because
you're live.
everybody's
You're live
because
on
everybody's
stuff.
looking at us right
You're
now.
definitely live on something.
Well, good evening, everybody. I am Dr. Rocky Victory, and this is Fertility Factor Fiction.
Maybe.
And we are trying something new to see if we got all the same time talk. So we're trying to. For those of you on TikTok, YouTube, Twitter, right? Just say YouTube. If there are any glitches, let us know in the comments. See me and Tarek in the background, who can actually break his fast soon as well. What time can you?
Let's just get this going.
I unloaded this on him about 10 minutes ago as we were exploring possibilities. Welcome to our show. This is the absolute coolest show on infertility on the web. It's our show we do every week where we break down the myths about infertility and talk about things that are hot topics out there and see if they actually work or they don't work. And hopefully save people a lot of time, energy, effort, and money, and some bad emotions when things don't go the way that they're supposed to. So great to have you all here tonight. And it's been a very, very busy and exciting time for us. We've had lots of conferences to attend and lots of business opportunities, and VRC is growing. We will be opening up soon into new communities. And so we're very, very excited about that as well. And opportunities as well, both national and international. So super excited to have you all with us on the show, and Tarek's trying to figure out if things are working. Is it working?
Yeah, I think it is. Just ask them if they can hear if the audio is
Clear?
if everything's okay. Yeah,
If the audio is clear, can you give us a yes, the audio is clear, or a thumbs up, or a heart sign, or something like that, or a like?
because it could be laggy. I'm just trying to figure out if it is or it isn't.
Well, it might be laggy. Okay, so tonight, because of some questions that people have been asking recently and some stuff that happened historically in the recent past, we decided to review HCG. I am working on alpha lipoic acid. I found a great article, and I'll probably bring that to you in a more formal video next week. But for now, we're going to talk about low dose H. Why is this important? Well, for a little while there, Menopur was not available. And a lot of fertility specialists like Menopur. I'm one of them. I love Menopur. And I also love many of the other drugs that are available, but Menopur is definitely one of my go-to medications, as well as Gonalef. I find that combination very potent, even though they're both from different companies. So when Menopur became unavailable, we were all scrambling, and people went in two different paths. Some people used Luveris, which is recombinant LH, and the main reason is that HCG has LH-like activity. And other people decided to just use low-dose HCG. Now, what's the theory behind this? Well, LH and HCG are very similar molecularly, but LH lasts much shorter time period than HCG does. And so the impact of HCG can kind of hang around in your body longer. So number one is that they're very, very similar. So people have also done some beneficial. Say it is. There are studies that overall, it can kind of mimic what the body is supposed to be doing better than the body does. So the second part of it is that you drastically, because a vial of HCG has 10,000 units and costs probably around $100, at least Canadian, and you can only use anywhere from 75 to 150 units. So you have many, many, many doses of HCG from just one $100 vial, whereas all these other medications are very, very much more expensive. So there was a cost-cutting measure, and then you get this supposed benefit from the HCG as well. So the question was, does this low-dose HCG approach actually benefit people? And I've started getting more and more requests from consults that we see saying, you know, I failed before HCG protocol. And I to me, and I don't necessarily believe in it, but I wanted to kind of bring you the latest and greatest data that's available. So I dug up a study that was as recent as possible, that was a randomized controlled trial. So keep in mind, as we always talk about in the show, there are different levels of evidence. Sometimes they tell you, oh, this is the best thing ever, like ovarian PRP. We tested it in 30 women and they all got pregnant. Yeah, well, that's not a properly done study, because if I take 30 and I, you know, throw salt in the air and tell them to walk through it, well, they're still going to get pregnant, and it has nothing to do with the salt that was in the air. But I can say it was the salt that I threw in front of them. So you have to have a properly done study. So this is one of the few randomized controlled trials. And it was the G. The study, the population randomly assigned, the population got placebo and didn't. They were getting the placebo. So the main question was any significant impact on the outcomes. So I want to kind of show. So can we screen share? Is it doable, do you think?
I think it might be.
You're having a field day with this, aren't you?
It's very
intense.
intense. It's very intense. I'm nervous that there's lags.
Okay.
Be laggy, so, but I can share the screen. It's here.
You're just going to need a way more powerful computer now.
That's a great thing to have.
Okay.
Rotate it this way.
Rotate it this way?
Yeah.
Okay. And then expand it.
Yeah.
How's that?
Perfect.
So the trial is called a randomized controlled trial on the efficacy and safety of low-dose HCG in a short protocol with GnRH agonist and ovarian stimulation with recombinant FSH during the follicular phase in infertile women undergoing ART. So I kind of chuckled when I read this, because as we get more and more sophisticated with what we do, people are like spelling out every single detail of the study. So let's go over the important parts. Number one, it's randomized. Number two, they're looking at whether or not low-dose HCG was safe and effective. Number three, they used a GnRH agonist protocol. That is not something that this with a grain of salt, like using or a microdose flare Lupron protocol. A short agonist protocol is just taking Lupron right around the time you start your stim. And then they used ovarian stimulation with FSH. One is not available in Canada and any of the other recombinants, which is the majority of FSH, and was in the follicular phase. So these were not duostim patients. These are patients that did a follicular phase stimulation. So they set out to get 50 patients in each arm of the trial, because when they did their calculations to see how many were needed, it was 50. But unfortunately, in the middle of this trial, they hit COVID. And when they hit COVID, they had to stop the trial because one of the guys running the trial left. And because of COVID, they had to stop it. So they prematurely stopped it, but they got 41 patients in one arm and 40 patients in the other, for a total of 81 patients. So I'm going to scroll through, oh, we got to go this way, sorry. Who they included and who they didn't include. So in terms of the criteria, you had to be age 35 to 40. So they wanted people that were 35 to 40 years old. They were looking at the patients that had normal menstrual cycles, anywhere from 24 to 35 days. They had to have normal endocrine function, so these were not like poor responders or anything like that. Normal prolactin and FSH less than 15, normal thyroid function, and no pathology like an endometrioma or a cyst or anything on the ultrasounds. no significant medical history, and they had to have a decent indication for doing the IVF, and it had to be either their first or second IVF cycle. So I actually kind of liked who they said they could include. Exclusion, if they had PCO, uterine pathology or endometrial pathology, high FSH levels, a BMI over 35, age less than 35 and greater than 40. So they really studied this very narrowly focused little group of people. So when they did the actual study, they analyzed the data and they looked at the different groups. So this is the data. Actually, this one I'll go back to this way, Tar, because it's going to look better this way. So this is the data on the demographic factors. So group 1 was the group that got the HCG. Group 2 is the group that got the placebo. There was no difference in age, BMI, previous number of pregnancies. There was no difference in the number that were smoking or drinking. Every single thing in the whole breakdown of patients was equivalent. And it should be that way in a randomized controlled trial because you're randomly assigning patients to groups. So they should all end up roughly having the same number of outcomes or demographic characteristics. So then they looked at the actual data. So now I got to go back this way. It's back and forth, back and forth. Sorry, guys. Okay. So the primary outcomes were clinical pregnancy. So did this low-dose HCG contribute to a higher percentage of clinical pregnancies? And the answer was no. You got 25% with HCG. You got 24.4% with no HCG. And the statistical significance was just clearly not there. The p-value should be less than 0.05. This was 0.9, so not even remotely. What about high quality embryos on day 3? I don't know why they would look at day 3, but in any event, no difference there either. They had 52% in the HCG group, 34% in the no HCG group. But when they looked at that statistically, again, there was no difference. Could it be different if we had more numbers? Possibly. But certainly here it was not statistically significant, and you would need a lot more to bring that significance level down. Was there a difference in the number of follicles greater than 11 at trigger? Nope. 6 in each group. Greater than 14? Nope. 5 or 6 in each group. Greater than 18? Only 3 in each group. Now this is also interesting because these guys had a hard trigger of around 18. And so they weren't really seeing that many follicles that were developing. One of the question marks with HCG is, does it make the smaller follicles kind of shrink and go away and promote the bigger follicles to grow? There was a study back in 2002 or 3, which actually showed that for PCOS patients, this was a great way to go. Get them started on your FSH, and then if they started super producing the number of eggs, drop them down to just low-dose HCG because only the bigger follicles would grow and the smaller ones would shrink. There's also evidence coming out that HCG actually causes death of the smaller eggs, and therefore you actually need to be really careful with it because it can cause cellular apoptosis, which is programmed cell death. And so it's very, very cautionary how much you use HCG and when you use it. So there can be some factors in there that are important. Estrogen level when they triggered, it was much higher numerically in the HCG group, as you guys can see there, 1770 versus 1100, but it actually made no difference statistically. Progesterone at triggering shouldn't be high, it wasn't in either arm. Endometrial thickness, the same. Number of eggs collected. These guys collected an enormous number of eggs on average from patients, 32 to 34 eggs on average. That is a huge number, especially for women that are 35 to 40, which made me think, this is odd. Number of mature eggs, the same. Moderate quality embryos, the same. Poor quality embryos, much lower in the HCG group versus the non-HCG group, and close to being significant. So 0.057. Not significant, but very, very close. So the one area where there may be a benefit to this is that you don't necessarily get as many poor quality embryos. So that's kind of an important thing to have a look at. Again, moving forwards, embryo transfer embryos, no difference. Frozen embryos, no difference. Cycle cancellations, the same. Spontaneous abortion, the same. And ovarian hyperstimulation syndrome, very rare in both groups. So that was not a major issue, although they did abandon continuing the cycles and canceled cycles in patients where they were at high risk for ovarian hyperstimulation syndrome. So what did they conclude from all this? They actually concluded, and you can stop sharing now if you don't mind, that there is actually no difference between the HCG and the non-HCG group. So does low-dose HCG actually help you? No, it is a fiction that low-dose HCG helps you. There are 2 meta-analyses on these, and both show conflicting results and have a lot of garbage studies in there, so it's not very well done data. But the bottom line is this is the best study available right now with good control of variables. They did multivariate logistic regression analysis, univariate. All of that showed that there was no benefit to the HCG. So at this point in time, we don't see a benefit. The other really important thing to recognize for those of you that do use Menopur is that Menopur is intentionally contaminated with a really small amount of HCG. So you're actually getting these microscopic little doses of HCG when you take Menopur. It's way less than they used in this study, but it's just enough to probably improve some of these egg parameters, embryo quality issues, and things like that. Now, in the Menopur versus Gonal-F studies, we've never seen an improvement in the embryo yield or egg yield or anything like that, but it was questionable as to whether or not there was an improvement in embryo quality. So an interesting thing to look at. So if you're thinking of using low-dose HCG, my recommendation is it may cut down your costs because there is no difference. So it's certainly not harmful from anything that's being shown here, but there isn't actually a benefit to using it. And it's kind of an unknown quantity right now. So it's not something that we're going to be supporting anytime soon until more data comes out saying there is a substantial benefit to this. However, if you are trying to cut down the costs of your meds, maybe it's a reasonable approach for you. You're certainly not going to get any difference in the outcomes. So if you can cut down your medication costs and still get the same outcome, maybe that's something worth considering. Hope you enjoyed that part of the show. And we will be back again next week for sure to review another hot topic, which will be alpha lipoic acid. And now we're going to move on to the live question and answer period. And please don't ask me what your specific success rates are. I cannot answer those questions, but I can answer general information questions for you. How's dinner?
Great.
Tarek's trying Persian food. If there's any Iranians out there, give him a big thumbs up. It's his first time trying it. How does it compare to the Lebanese stuff?
You're right about the rice.
It's way better. The rice kills.
The rice is nice.
Yeah. And what did you think
Very
of the yogurt?
Oh, the cucumber is.
It's good, eh?
It's really good, actually.
Yeah. There you go.
I'm
All right.
surprised how good it is.
Yeah. Go Persians.
Go Persians.
Yeah.
Hello, doctor.
Hello.
We only have 3 frozen embryos.
Okay.
Day 5, 3CB, 3CC, and day 7, 4CC.
Okay.
Are these even worth transferring?
Oh, okay. So I can't answer specific questions like that. I can just go over quality and I can reference studies and things like that. So let's just quickly talk about what the numbers and the letters mean. The number is the degree of expansion of the embryo. So how expanded out is it? Is it really compact still? Is it starting to expand? Is it expanding? Is it fully expanded? Hatching or hatched? Okay, so you get a 1 to 6 score. And the answer to the letter, the first one, is it is the grading given by the embryologist after looking under a microscope to the quality of the cells that are going to become the baby, the inner cell mass. The second letter is the quality of the tissue or the cells that are going to become the placenta. So we know that A and B quality embryos are very good, and there is very little difference between a B and an A quality embryo. So very, very minimal difference. But we do know that with C quality embryos, in particular when it is the trophectoderm, the placental portion, which is the second letter, that can have a very significantly negative impact. Does it mean you won't be successful? No, not at all. There are people that succeed with CC quality embryos, but it does definitely diminish the quality and the end result. And we did review a study on this, gosh, I don't remember, probably about 5 or 6 months ago, which showed that there is a difference in the outcomes, statistically speaking, between the C quality embryos and the A quality embryos. So yes, you will see a decrease there. Day 7 is very controversial. If you have an untested day 7, meaning it's not PGT tested, the chances of success are definitely lower in most studies. A PGT tested day 7 is controversial, although we don't generally keep our day 7s because I don't believe that the results are very good or justify the expense of using them. But some people do. And there are studies that say that with a normal, genetically normal euploid day 7, you'll still get equivalent chances. And then there are other studies that say you don't. So the most convincing data I've seen said that your chances were only about 15% with a day 7. So I can't tell you specifically for your case what to do. You have to review that with your doctor. But those are the things you need to know in order to make a decision. If your IVF cycle is insured or it's free and you can try again, there certainly are ways to improve quality, and those are things that you need to talk to your RE about. And there are many lab techniques, there are personal techniques, there are stimulation protocols, all of which can kind of tweak things to improve it for you. But if you're paying for this out of pocket, I guess my question would be, what's the harm in trying embryos first? And that's, again, something you've got to review with your lab, or not your lab director, your RE, to see what they think about the embryos that you have. One thing I would definitely recommend to everybody is do not feel pressured to go do more IVF cycles because people are telling you to go do more IVF cycles, because most centers are generating their income and funding their lives through selling IVF cycles. And the goal is not always necessarily what's in your best interest. Sometimes it's what's financially best for, everyone involved. So I would be very cautious about that. Make sure you have all the data that you need to make a decision that is right for you. Great question, by the way.
And letrozole with injections, IUI cycles.
Okay, wait a minute. So there's a fork and a knife and a spoon that I brought you.
Yeah.
And you've been eating, but they're all still here.
Yeah.
What are you using to eat?
The yogurt spoon. I didn't know where to put it. I was worried wherever I put it, it's going to make yogurt mess. So I just said, might as well just lick it off. And
I was like, is he eting with his hands over there? What's going on? All right.
For the sake of cleanliness.
For the sake of cleanliness,
Yeah.
I get it. Okay, thank you. Yeah.
And letrozole with injections, IUI cycles. Do you add progesterone supplementation for your patients? Continue. Based on your high prog for endo patients video,
Yeah.
would this apply to IUI prog supplementation
Yeah.
as well?
Yeah.
Would you do endometrium for IUI cycles, and what dosage in general?
Wow, that's a lot of questions. So in general, the progesterone for IUI, we do offer patients and we typically do use it. We have not taken to adding extra prog for endometriosis patients in IUI because I'm not aware of any evidence that looks at that, although that sounds like a great topic and maybe we can try that to look for something for that. I've only seen it for IVF. So we haven't been bumping up our prog doses for the IUI patients. Endometrium comes with its own dosing regimen, which is 1 tablet 3 times a day. That's standardized for everybody. So I don't think you need to change that or alter that in any way.
Hey, Dr. Victory, would you accept a patient from outside of Windsor area? I'm located in London, but our fertility treatment and IVF list takes a very long time.
Yeah.
Also, what's your opinion on Ozempic? That's a big one these days.
So we definitely take patients from everywhere. I have patients from Australia. I actually have a patient coming from Australia soon. I've got a couple that just picked up their meds a little bit ago from Denver, Colorado. We have people coming from Italy to us. I mean, this is a very international location. People come from all over the world to us. So London, Ontario would be no problem. As far as getting you on our funding list, no problem. We're happy to put anyone in Ontario on our funding list who qualifies for funding. That's also not a problem, and we're happy to accommodate. That's not an issue at all. With regards to Ozempic, I'm not a believer that people should use medication to control their weight. I believe people should. All of these medications have side effects. So I talked to a patient recently who used Saxenda and had horrible vaginal itching and irritation to the point where we had to do a biopsy until we finally figured out it was the Saxenda that was doing it. There's something called Ozempic face, where your face gets very wrinkled. All of these medications have side effects which are unnecessary to experience if you just diet and exercise. As much as weight gain and weight loss are difficult things to deal with, it's math. And no matter how much people want to watch this video and that video and take this fad diet and do the Atkins and do the low carb and do the HIIT training and all that stuff, it's all irrelevant. It's just plain math. If you take in less calories than you are burning, you're going to lose weight. It's biologically not possible to not lose weight. So if you take in 1,500 calories and you burn 2,000 calories, you're going to lose weight. So making sure it's fatty weight requires exercise because you want to deplete your glycogen stores in your liver so that your body then turns to your fat supply. You don't want to be burning up muscle. But as long as you diet and you exercise appropriately, it's math. So don't use Ozempic, is my opinion. I strongly believe people should be using a combination of healthy diet and exercise to get themselves into the right shape. Now, the one exception to that is if you're diabetic and you need Ozempic because you're diabetic. So if your doctor has told you take Ozempic for diabetes, great, that's a different story. But if they're telling you to take it for weight loss, I'm sorry, it's a cop-out. It's like, basically just saying, I couldn't handle the other stuff, so here, take this pill or shot and it's going to make you better. It's not necessarily going to make you better, and it does have side effects.
Hi, handsome twosome.
Oh, excellent. You're off screen, so that's, yeah.
Still feel
But
really
he's,
good about
yeah, he should feel good about it. He's a very handsome guy, and I love him dearly.
Can you talk about split dual stim
Oh, yeah.
in more detail?
Sure.
What do you look for when monitoring for the luteal stim, since labs and ultrasounds aren't like the follicular baseline?
Sure.
Does the max number of days to stim stay at 12 for luteal stims too?
Yeah, those are all great questions. So split duostim was an idea I kind of came up with because we were seeing with our follicular phase that we were getting like 8 eggs, let's say 6 eggs, 8 eggs, 10 eggs, whatever it was. And then when we went to do the luteal, because we were taking out a lot of the eggs at the follicular, there weren't that many at the luteal. And I thought, well, what if we just not do the luteal phase in this cycle, but wait and do it in the next cycle? Maybe we'd have a lot more eggs. Sure enough, it very much looks like that's the case. And so you get a lot of these luteal follicles in the luteal phase, which is great. And we do think that in our experience, we're seeing better embryo quality, better egg quality, and definitely higher numbers when we do it this way versus the other way. So I'm very happy with the split duostim. What do we see in terms of labs? Well, your progesterone level is going to be high because you would have released an egg. So you just ignore that, and that's okay. And your estrogen level may be a little bit higher than you would anticipate at the start of your follicular phase, but it will go up again as you stimulate the patient, and that's fine. As far as the stimulation duration is concerned, it definitely seems to take longer with the luteal phase. So I am breaking my 12-day stimulation rule with our luteal phase patients because many of them take longer than that just to kickstart the growth of the eggs. Not quite sure why that is yet, but we are seeing people that need like sometimes 14 days with a luteal stim. We're still getting great egg quality, but it can take them a lot longer to get there. So great question. Split duostim is doing your follicular phase 1 month and then not following immediately with the luteal phase, but rather waiting a month, passing your next follicular phase, waiting for you to naturally release, or you can stimulate the release and then go chase the other follicles down.
It's a different person.
Okay.
One was on Facebook, one on YouTube. Like they're completely different questions.
Okay.
Just bear with me here.
Okay.
So instead of hi, handsome, twosome,
Okay.
it's now just hello, Dr. VNT.
Okay.
Is this how you do the split dual stim, follicular stim and egg retrieval, then wait for a period, then do a luteal phase stim?
Yeah, that's what we just said.
Oh,
Yeah.
but
There
it's
you
just
go.
interesting,
Yeah.
back to back.
Yeah.
I prefer.
We had one in the pre-questions too on
Yeah,
on
Instagram.
Instagram. Yeah, you got to go through those if you don't
I
have.
will go through them for sure.
Excellent.
Yeah. What do you typically see as the most successful treatment options progression for severe endo patients stage 4 with cysts post laparoscopy?
I mean, if you're talking about most successful options for getting pregnant afterwards, then your options are going to be try natural, do insemination, or do IVF. Those are the only things that are available, obviously. So there's no question IVF has a higher success rate. I'm not encouraging you to jump into IVF. I'm just purely talking success rates. So IVF has the highest success rate. If your tubes are functional, which is a big question mark with stage 4 endo, IUI would be reasonable, and then natural would give you your lowest chance. So IVF will definitely provide people with the highest chance of success, but it has to be done properly. In my opinion, garden variety IVF cycles for endo patients is a waste of time and money. I think they need a lot more care and specialized protocols that focus on the fact that you have endo. We want to keep your estrogen low. We need to keep your progesterone high. Never do a fresh embryo transfer. It should almost always be frozen. Suppression prior to the transfer for several months. Some of those endo patients need immune protocols to tamp down the fact that their pelvis is, kind of inflamed all the time. So there's a lot that goes into a properly done endo IVF protocol. It is not the cookie cutter approach at all.
Hi, Dr. VNT. Can you explain how low dose HCG is used in a modified natural FET and is it effective?
So low dose HCG in a modified FET is being used for luteal support. So in addition to or in place of progesterone, you can give the patients HCG to support the luteinization of the lining of the uterus. And to provide support for the, stimulating the growth of the placenta to use the HCG for its hormone purposes. The reality is there are many studies on that, and not a single one has shown that it's better than just giving patients progesterone. I never do it because you got to take it as a shot. And yes, it hurts a hell of a lot less, and it probably is a little bit cheaper than PIO, but PIO is the gold standard, and we've stuck to that. So there are no studies that show that the low-dose HCG or HCG luteal support in general improves your outcomes at all.
Ready?
I'm always ready.
This is an interesting one.
Yeah, okay.
When I read it, I said, this is interesting.
Okay.
My OB, so we start with some caution here.
Love it.
Yep. My OB told me this morning
Yeah.
during my PAP
Okay.
that they can tell there's a shift in hormones. I just finished taking Provera yesterday. What does a shift in hormones look like when you can see inside?
My OB told me during my normal PAP
Yeah,
that I had a shift in hormones.
that's right.
I mean, there are changes to the cervix that we see. Maybe that's what they're referring to, but cervical changes, we don't look for hormonal changes in the cervix. I mean, there are some subtle ones, but it's so variable. I've never once in my entire career looked at a cervix and said, oh, that one looks like it's got too much estrogen or not enough progesterone or anything like that. That's virtually unheard of. Yeah, that's a very interesting question. You're right. Yeah.
I told you.
No.
I'm not a doctor, and I said, this is a piece of work.
That's
here.
probably some seriously old school OB. It's not something that we look at in a modern practice at all, ever. We never explore that.
Do you find
Cool.
IUI is as effective in endo patients as other patients?
No, I mean, endo patients in general have reduced success rates with everything that they try in infertility, including IVF. So IUI is the same. It's not as good as it is for someone who, for example, has PCOS or mild male factor or something like that.
Is it safe to soak in a bath while pregnant?
Yes, no, and maybe. So the
Wow.
problem with,
All
yeah,
that.
I got all of it, right?
Wow. Okay.
Here's the problem with soaking in a bath. And you know what? This will make a
It's a great
perfect,
one. Absolutely.
perfect separate video for you. Yeah.
100%.
Okay, so for women who are taking hot baths, the number one problem is that your body realizes that your skin temperature is very hot. And so it takes all of your blood and it brings it to the surface of your skin to try and make it cool because it doesn't know that you're submerged in water. So it tries to make you cool by bringing the blood to the surface so your veins start to pop to help you cool. That's why when you're really hot, your veins come up to the surface, and when you're cold, your veins kind of retract inside to keep you warm and to keep the blood warm. So the problem with that is you're taking blood away from your baby and from your brain and your heart. When you go to stand up out of your hot bath, all the blood is in your skin or near your skin, and therefore less of it is going back and forth to your heart and your head. And then there's gravity as well. And when you go to stand up, you are very, very high risk for passing out. Where is the one worst place to pass out? In a bathtub. Because if you clonk your head, which is very likely, you can pass out and now you're drowning. So we never recommend prolonged hot baths for women when they are pregnant. And if you are going to take a hot bath, make sure there is someone there to help you out of the bathtub when you go to get out. Never lock your bathroom door and never stay in for very long. A warm bath is fine, but don't take hot baths like some people that I know, my wife included, who come out of the bath looking like a lobster every time because she likes it scorching hot. I cannot get in the bath that she loves to soak in because it's so hot. So that's probably intentional in her case because she likes her bath time. Yeah, definitely don't pass out when you get out of the bathtub.
I love the individualized rice.
Did you? It's nice, eh? Yeah, yeah.
Somehow I'm eating more rice
Yeah.
than meat.
Did you find that like sweet taste to the meat a little bit?
Yeah.
I think
It's
it's soaked in
interesting.
pomegranate, but anyways. Yeah.
Hi, Dr. V&T. How soon before or after ER can I do HSG or SIS test?
Oh, I'd probably give it a week or two, but you could do it right after that as long as you're not pregnant. I mean, you'd probably be best to wait for your next period.
What mild adenomyosis affect implantation? Can mild adenomyosis affect implantation?
It depends on what study you read. So some studies suggest that adenomyosis very much can impact implantation. Other studies say it doesn't. If it's mild, my kind of gestalt would be it probably is going to have very little impact. If it's more significant or you have an adenomyoma, which is like a fibroid but of adenomyosis, those are probably more harmful and cause more problems. So adenomyomas you got to be cautious with.
What HCG level would you like to see for your first beta after FET?
It depends on what day they're testing. We're usually looking for a minimum of 150 14 days after a day 5 embryo transfer. Minimum of 150. We prefer seeing 300, 500, 600, but minimum 150.
We got some TikTok action going on here.
Okay.
Just trying to find ourselves here. Oh, Habibi, welcome. Here we go.
All the way from Holland.
All the way from Holland. That's right. All the way from Holland. It's time for questions. For future as TTC, one pregnant with a moderate cervical stenosis and... Question 2 did not make it.
Uh-oh.
That's all I got from that question.
Okay. If you have cervical stenosis, your options are IUI, IVF, or just have them surgically stretch open your cervix. It takes 5 minutes. It's easy.
Is hydrocortisone or Betaderm for eczema safe to use during pregnancy?
Talk to your doctor. I cannot answer questions like that, but as far as any pharmacy knowledge is concerned, there are no contraindications written on hydrocortisone for use in pregnancy. But talk to your doctor.
I think you're her doctor.
Then talk to me.
Okay. What HCG level would you like to see
No, you asked
for
that.
your? Oh, I did. Sorry.
Yeah.
There's a lag on everything.
Is there?
It's new computer tomorrow. Does an IUI usually involve medication as well? And if so, which would be recommended?
Yeah, so you don't have to use medication with an IUI. You can do your natural egg release with an IUI. You can use oral medications, which are typically either Clomid or Letrozole, or you can use the injectables with the oral medications, which cuts down your use of injectables, or you can use just the injectables. So which one should you use? It very much depends on your history, your age, how many times you've tried these various things. So that's a question you got to discuss with your RE, but there are different options available for sure.
Hey, Dr. VNT, I'm 7 days into an IVF cycle, starting to get some light cramps. What can I expect closer to egg retrieval day and post ER?
Oh, so leg cramps should not be happening unless you're either low in something like calcium, magnesium, or you're getting poor blood flow, and you do not want to have poor blood flow when you're doing IVF, because if your estrogen levels are rising quickly, you can very much run into trouble with blood clots. So anytime you're having leg cramps, I would strongly advise that you follow up with your fertility center and let them know, because that's something we would all take very, very seriously, because you do not want to get a DVT or a pulmonary embolism. So be very, very cautious about that. Make sure you let your RE know. And if it's us, I need you to come in tomorrow so we can figure out what to do. I don't know how you're reading that. That's got to be like 0.5.
There's a lot of work, a lot of effort today.
You're going to need some magnifying glass
What
for that.
What is your 12-day stim rule?
Oh, so there's evidence that shows that if your stimulation goes too long, the egg quality starts to decrease. Now, it depends on how things are going. So if you're already doing well at the start of the cycle and your doctor is making you wait because they want to get 10 extra eggs and now your follicles are huge, that's a bad plan, because you'll really compromise the overall quality of the batch of the eggs. But we do get some patients where they don't respond well in the beginning, and so we have to kind of extend it, because really their cycle didn't start till they were a couple of days into it, so their day 12 might be really more like a day 10. So it has to be very individualized, but as a general rule, you don't want to let people stimulate for more than 12 days because it compromises egg quality and outcomes. And we've reviewed that on a show years ago, actually, and talk about it all the time. So I see lots of centers where they go on and on and on, and you're looking at it going, oh, like, she had 25 follicles and some of them were 25 millimeters, 26 millimeters. That's way too late. You don't need to wait that long to get the extra eggs. A few good quality eggs is much better than 20 not great quality eggs.
Have you found more success with patients getting pregnant after removing endometriosis?
I have personally, for sure, but more importantly, the EndoCan study, which was a randomized controlled trial of laparoscopy for patients with endometriosis, demonstrated a huge increase in success. It went from 26% to 42%. Or 46%, I can't remember right now, but it was a gigantic leap forward in success. So categorically, there is evidence to support that after endo surgery, patients do better. That's with mild to moderate. If you have severe endo, it's a different story.
Mosaic embryos from IVF, 38, low AMH, low chance for pregnancy naturally? Question mark.
Yeah, so the current theory on mosaics is that it depends on what kind of mosaic. So there are low-grade mosaics where, depending on who's scoring it, less than 50% of the cells have an abnormality, and high-grade, which obviously is more than 50%. Grades are generally considered to be abnormal. More and more people are accepting that the low grades, especially if they have a really low percentage of abnormal cells, like 20% or less, are actually normal and should yield the same outcome as a euploid embryo in terms of chances of achieving a normal live birth. So we are happy with the low-grade and the low-grade mosaics. The high-grade mosaics we will not transfer because they're not normal. And the chance of success is like less than 1%, so it's probably not even financially reasonable to do it.
Do you recommend women take the supplement choline while pregnant or preparing
Choline?
Choline, yeah, while pregnant or preparing for pregnancy?
I'll leave that kind of thing for our naturopath to decide. We don't recommend it, but I have to admit freely that's not something I specialize in. So anything natural like that, we talk to our naturopath. I do think that we will be adding alpha lipoic acid to a lot of the stuff that we do. It does look like that is very potent at improving many different facets of infertility, including using it in the lab. So there may be some real benefits to that. And we'll talk about that next week.
How many days after the last Provera dose does the period onset?
Usually 4 days. Usually.
Do your patients who end up pregnant stay with you the whole pregnancy or transition to a regular OB?
Well, I am a regular OB as well, I guess. Well, I guess I hope I'm a good OB, but
More than regular.
I'm regular. So, yeah, many of our patients stay with us. It depends on where they come from. So, if one of my colleagues in town referred the patient to me and said, please send them back after you get them pregnant, of course, out of respect, we send them all back. But if it's a family doc that's referring the patient to me, I find most of our patients want to stay with us for the obstetrical care in the pregnancy. So those ones will stay with us.
Can a pedunculated submucosal fibroid,
Pedunculated.
it's very hard to read.
Yeah, that's a very small font.
Right, just to make sure every window's working.
For those of you who are trying to imagine this, he's reading this off of font that's about minuscule off of this tiny little screen. And his face is about an inch away from the computer.
It's sight to see.
Yeah, it is. Yeah. Pedunculated fibroid.
Yeah.
Submucosal.
Submucosal in the uterine cavity cause a miscarriage.
Yeah, it doubles your risk of miscarriage. Anything submucosal, a 0, a type 1, they can cause a miscarriage. It doubles your risk of miscarriage. So you should definitely have those removed. There's no question. That's a universally agreed upon thing.
Is progesterone PIO helpful for natural pregnancies? If yes, when would one start taking them?
So we just reviewed this recently. Was it 2 weeks ago on the show or last week on the show?
Yeah.
That progesterone for miscarriage does not help to prevent it if you show up bleeding. Your question, though, is should you take it in a natural pregnancy to prevent a miscarriage? And the problem is no one's ever looked at starting it ahead of time in order to prevent a pregnancy. So I've never seen a PIO for a natural pregnancy. That's a lot of trauma for something natural. PIO hurts like a son of a gun and is not comfortable and does have cost. So it's not something we would advocate, but I'm not aware of any studies on that. There may be some. I've just never seen it. Here, dude.
Got yogurt all over the place.
I see that. As long as it's not on the Persian rug, we're good.
You're good. You're good. You're good.
Excellent. If I see you down on the floor with the Kleenex, oh no, yeah.
When pregnant with a moderate cervical stenosis and arcuate uterus.
Yeah. Well, that was the moderate stenosis question.
No, there's more here.
Yeah, I know, but that was the one she was asking.
TikTok has a character limit.
Yeah.
And accurate uterus. Is there issues with labor, vaginally versus C-section? Sorry, TikTok has a character limit.
Yeah, no problem. That's a great question. So the cervical stenosis and arcuate uterus cause a problem with labor. Arcuate uterus should not cause a problem with labor at all. I guess maybe a very slight increase in your chances of having a breech baby where the baby is upside down, but aside from that, no. And that would be negligibly small. With regards to cervical stenosis, I guess in theory, yes, it might be harder for your cervix to stretch open. So that could necessitate either a longer labor or requiring a balloon to assist with opening or prostaglandins or a cesarean section. It's possible. I don't think there's a way to pre-assess that or predict it. There's no way to know in advance. You get women with badly stenotic cervices, from LEEP procedures, cone procedures, where they've had cervical dysplasia and their cervix pops right open, and then you get other ones where nothing you do works. So it's hard to know. There's no predictive factors for that. You're loving the yogurt. I told you you'd like the yogurt. Yeah. Yeah. Tarek's in love with something called moskhiyar, which is this Persian, I guess it's an appetizer, mainly made in the summer, where, don't get grossed out, folks, we put chunks of cucumber, raisin, herbs, and my family usually puts in walnuts into yogurt, and then you eat it, and it's amazing. It's very refreshing.
Very refreshing.
It's super, isn't it? Yeah, it's very refreshing. Yeah, it tastes amazing.
Hello, my dream team.
Dream team, that's us.
Multiple thumbs up.
Excellent.
What determines the stimulation meds you get for IVF? I'm only getting Menopur for stims. Is this sufficient to stimulate follicle growth? Thanks.
Well, your RE determines the stimulation meds, right? So their experience and their, understanding of your physiology, hopefully, and their protocol and all of that. So there are lots of studies looking at the different protocols. To be honest, there are very, very, very few which have ever shown that one approach is superior to another. I advocate for our approach based on very simple scientific principles, which is recombinant FSH has been proven to help make a high number of eggs, and the urinary FSH seems to be helping with egg quality and embryo quality. So we mix the two so that we get the best of both worlds. So that's our approach, but your doctor has to decide what's right for you, and you have to talk to them.
Do you only find out embryo grade if you do the PGT testing?
No, embryo grade is something called a morphologic score. They're going to grade your embryo before they freeze it and after they thaw it, because they're going to look at it under a microscope to determine if it's good or if it's bad.
Supposed to start MDL on CD2. What if local monitoring center isn't open to monitor until CD3?
Oh, I wouldn't worry about that. Yeah, I mean, you can start on day 2 and then go for your monitoring on day 3. As long as your drugs are covered, it won't make a difference. Yeah, it won't make a difference. Don't worry about that, guys. 1 day doesn't make a difference. Excuse me.
Is sex safe in early pregnancy that happened from IVF? I'm 9 weeks and 4 days.
Yes, just take it easy. I always tell everyone, please don't swing from the chandelier. So please take it easy. Don't go crazy with sex, but gentle sex is fun. What we normally tell our patients is please make love, don't have sex. So gentle, loving, tender, nothing crazy. Put away the 50 Shades of Grey kit back under the bed. Under the bed.
There you go.
Yeah.
Hi, doctor.
Where the monsters are.
Yeah, that's...
Yeah.
Yeah, absolutely. I have a day 6 3CB PGTA tested normal embryo. What do you think the success with this embryo will be? Thank you. No age, nothing given.
Yeah. I can't answer questions like that. It's impossible. All I can tell you is that euploid embryos have a reasonable chance of success, and C-graded embryos are definitely lower than A, but there is always a chance, and no one but a crazy person would tell you not to transfer a euploid embryo. You got to go into it prepared for your success and failures, but I don't think that anyone would ever tell anybody not to try a euploid embryo. Maybe there are some people that would. I'd love to hear the arguments against transferring a euploid embryo. It wouldn't make a lot of sense to me.
Can you just ask them audio quality, video quality, lag?
Didn't they give you any thumbs up?
I got nothing, but if people are asking questions, they completely bypass the question.
So Tarek wants to know if there's any lag in the audio, video quality, anything like that, because we've merged TikTok with all of the other platforms tonight for the first time ever, after watching a YouTube video. So there you go.
Yeah, so
Tarek's about to buy himself a very expensive
you better
laptop.
believe it. You better believe
Some
it.
super high powered. It's going to be like a
gonna fly
desktop
in here.
replacement. Yeah.
It's going to be delivered by a drone. Would you recommend the NIPT test with a pregnancy with a PGS
PGT.
tested embryo?
Only if you are extremely concerned, should you do that. So PGT testing usually has over a 98.7% or greater, predictive value. It's normally, going to be correct. So there really is a very low chance it's going to be wrong. But if you want extra reassurance, doing an NIPT test is harmless. So there's no reason why you can't do it. Many patients do it just to confirm. And in Canada, more and more patients are doing it to determine what the sex of the baby is, which we do not support, and I don't recommend doing that.
Can you still get pregnant naturally if you don't have any egg white cervical mucus?
Yes, that whole cervical mucus thing is nonsense. Total nonsense. Yeah.
How much does normal PGTA overrule lab grade like 4cc in your practice?
So in other words, if you have a euploid embryo, but the embryo is a 4cc, would I override the fact that it's a 4cc because it's genetically normal? I would to some extent. I mean, I would be willing to transfer that. It would depend on what else was available for transfer. So if I had better embryos, I'd use those first. If I had the opportunity to do more IVF, I would do that first. But if I only had a 4cc euploid, then I would probably say that's fine. Would I accept a 4cc euploid from another center? No. So we do get people that have euploid embryos that are not meeting our grading criteria. Those are not embryos we would accept here because you are going to see a decrease in success, and we like to keep our success rates very high. We're getting 82% with one euploid embryo right now. So I like keeping my success rates as high as humanly possible.
What question? So I like this question a lot.
Okay.
Okay. So what question should I be asking my wife's RE when preparing for our first IVF cycle to ensure she gets the best care possible?
Oh, that's a great question. I can't say that there's one question that I'd ask. I'd probably be asking a bunch. How much experience do you have? What was the last scientific article you read or major change you made to your practice based on something you read about? What was the last conference you attended? How often do you do research on things? How often do you study a topic? All of those things are important to make sure that they can provide you with the best care possible. What are my options? Which is critical, because if you walk in and they say you need IVF and you don't even know why you need IVF, that's not a good experience right from the get-go. So I would definitely suggest that you need to know what all of your options are and then ask them what specifically they are proposing for your wife's IVF cycle, and then say why. Why are you using these medications? Why are you proposing this protocol? How long are you going to allow her to stimulate for? What does the lab do with my sperm and my eggs after we have them? What's your embryo growth protocol? What kind of machinery do you use? Like, I kind of have to give you an entire degree in RE in order to get you to understand all of the different things that go into it. I guess what I would really say is you have to trust your RE. And I'm not suggesting you blindly trust your RE. I'm suggesting that your RE has to demonstrate that they are worthy of your trust in order for you to go ahead. Because none of us have the capability to teach everybody all of RE. I mean, I did 4 years of medical school. I did 5 years of residency. Then I did 3 years of RE and then 20 years of practice. So I can't teach that. Like, it's impossible. There's a wealth of information and experience and knowledge, and I'm still learning every day, and it's just not something I can do to teach somebody that in 5 minutes. So what I need my patients to do is feel comfortable enough with me that they recognize that I know what I'm doing, and therefore I'm going to do the right thing for them. And that's what you really need to feel with your RE. Is that a fair answer?
I actually like it a lot.
There you go.
I like it a lot. think that applies to a lot of things in life, to be honest. I think that was like a holistic answer.
A holistic answer, yeah. All
I
right.
endorse that answer.
And I am running for president.
I trust you. I give you the trust.
There you go.
Cycle with letrozole. My RE says 28 millimeter follicle is great size to trigger on day 13. Is that okay? Day 11, it was 21, but my lining was too thin, 4.9.
So I don't know what kind of cycle you're doing. If it's IVF, there would be a high likelihood that a 28 millimeter follicle would be post-mature. If you're doing IUI, the IUI studies show that the best time is between 19 and 21 millimeters. I've never seen any study that suggests you should allow the egg to grow that large. So I can't say that I agree with the 28 millimeter theory. But if your lining was thin, I would have triggered and then started estrogen.
Do you test progesterone levels before and after transfer?
Yeah. Day 3 of your progesterone and the day after your transfer, and sometimes in between day 3 if we had to adjust you on day 3. So, for example, if you're too low on day 3, we'll bump up your progesterone and check it on the day of transfer. And then again the next day to make sure it's stabilizing. If you're too high, we drop it down and recheck it. If you're stable, we just recheck it on the day after transfer.
Does surgery to fix an isthmus seal prevent an embryo transfer for 18 months?
What? No, not even remotely close to that long. Absolutely not. I don't know where that came from, but no.
Since it's like getting a C-section all over again.
Well, a C-section, even a C-section, okay, so it depends on how you're repairing your isthmus seal. If they're removing the isthmus seal surgically, then you would, I would say that you definitely need another cesarean, in which case you don't really need to wait more than 6 months. If you are having the isthmus seal resected or cauterized, you don't need to wait at all. Like whenever you're ready, you're ready. I have no biological reason to believe you would need to wait 18 months. Even in studies that have looked at the risk of uterine rupture in a TOLAC, which is a trial of labor after a cesarean section, it's roughly a doubling or a 2.2-fold increase in risk if you are less than 24 months. And the majority of that is if you're less than 18 months interdelivery interval. So from birth of one baby to birth of the next baby, which means you got pregnant again prior to your first child being 9 months old. So if you got pregnant when your first child was 6 months old, you've now got a 15-month interdelivery interval, and that's going to increase your risk of a rupture during an attempted trial of labor after a cesarean. But if you've had an isthmoseal repair where they're removing part of your uterus and then sewing it back together again, that's like having a myomectomy. You should not try to labor. You need another cesarean section, in my opinion.
My lab determined my embryo to be BB or BC. They put a question mark on the second letter. Why is that? That's great.
Yeah, I mean, that's a non-committal embryologist, right? Like, you got to commit. So it's either a B or it's a C. They don't have B question mark C. You're either a B or you're a C. There's no in between. I have heard of people giving like plus and minus grades. It's not part of most of the standard morphological scoring things. We have been going on forever, you know. We missed the time. It's past 9.
Okay.
How many are left?
I think 2.
Oh, okay. Let's answer the last 2.
What is the timeline for an FET embryo transfer?
Oh, it takes us about less than a month for the whole thing, from the start of the very first med, which is in the cycle preceding your actual embryo transfer cycle, all the way through to where we do your transfer.
Anything I can do? Got pregnant after a miscarriage last June.
There must be a first part to that.
No. Is there anything I can do to get pregnant after a miscarriage?
Oh.
Miscarriage was last June. Maybe that's what. being applied?
Well, we would need to know what was wrong, right? So what you can do is see your RE and figure out what's wrong. We have to do testing for you to determine what the problem is. That's it. Awesome. Well, thank you all for joining. I hope it wasn't laggy. I don't know if you guys
No,
ever
they said
answered.
They said it was pretty good. They said
was
at the
good.
beginning there was a little bit of lag, maybe when you were screen sharing, because there was a lot.
Oh, a lot for the computer.
Yeah, but after that,
It evened out.
it evened it out.
Cool. Well, hopefully it'll get better and better with a stronger, faster computer. Looks like you're going shopping, buddy.
YouTube, here I come.
I wonder if it'd be better on a Mac. Is that the kind of thing a Mac would be better at?
Don't start that. Mac or PC.
All right, guys, have a great night. Thank you for joining us on Fertility Factor Fiction. Myself and Tarek Ibrahim from Ibrahim Strategies Group welcome you every week. Join us next week, alpha lipoic acid. We will talk about whether or not it looks like it's going to help you in your cycle. Have a great night, and we will see you again next week on Fertility Factor Fiction.